Hello, this is Zweli Tuniswa, CEO of Open Wound Research and host of the Open Wound Research podcast. And I'm very glad today to welcome Dr. Desmond Bell to the podcast. How are you doing, Dr. Bell?
I'm doing great, Wally. It's so great to be with you today. Looking forward to this.
Likewise, I we last spoke at SOC, and I had frankly forgotten a little bit about you because we hadn't seen each other for a while. And when I saw you up at the poster hall, I thought to myself, we've got to get Dr. Bell on the podcast because you've been in wound care for such a long time. I think it would not be inaccurate to call you a denizen of wound care in that sense. So I'm very glad that you accepted the invitation. I'm very glad that you're here today.
Uh, Listen, how could I say no? First of all, but really honored to be with you. I've enjoyed so much, our collaborations to date, and so listen, we're all working towards the same things within this community. A lot of us have grown up in this little world, in a sense, but we have a lot of work ahead still. So glad to be part of it.
Absolutely. So, to get started, let me just run down a little bit about your education, your professional career, and your professional associations for the audience. You received your education undergraduate from Tulane University in the great state of Louisiana. You then completed your doctorate in podiatric medicine at Temple University. Go Owls, I guess. And you then completed your residency at the Veterans Administration in Philadelphia. Is it the one that was on Penn's campus, or which one did you do that at?
Yeah, the VA in Philly was literally across from UPenn. So we probably ate at the same lunch carts and all that sort of thing over time. But great experience. Philadelphia, what an amazing city, really, as was New Orleans too. I can't diminish that. Having that experience to go off to college in the South, and never having been away from my home in North Jersey where I grew up. I had never been on an airplane before I visited campus as an 18-year-old, and just fell in love with it. But needed to come back home. Worked for a few years actually before returning to school. But the experience in Philadelphia really led me to my career and this journey in wound care, amputation prevention, and so on. So it's been quite a ride.
Indeed. While preparing for the show, just going over your resume, just extraordinary career. It's remarkable all the things you've done, and over the next hour we'll talk about well, not everything because that would take up multiple hours, but many of the highlights that I thought were pretty remarkable. You finished your residency, and then in your professional career, let me run this down real quick because this is the abridged version, people. You start First Coast Diabetic Foot and Wound Management Center. You then set up Wound Care on Wheels, which, in my estimation, is one of the first mobile wound consultancies in the country, probably right up there with Northeast Surgical in Ohio, etc. You then start up the Limb Salvage Institute. You do a bucket load of consulting all for many companies that people recognize. And then in June 2024, you start work with CapSecure and then with Omeza just prior to that in 2019. And then I think this is kind of a passion you have right now. You start the Save a Leg, Save a Life Foundation, where you are founder and president emeritus, which I believe is like a benevolent dictator, right? Is that what that is?
Kind of like being the dad who still lets the kids play, but still gets involved.
Absolutely. It's funny whenever I see President Emeritus, my friend has a joke. He's like, "That's a benevolent dictator for life."
Got to reel them back in. No, I'm only kidding. Yeah, so in hearing, some of that, that overview of, the course of my career, the arc of my career, there's a tale in there. And all I can tell you is that to me, as a kid, the definition of what it would have been to have made it would have been becoming a physician and having a pool in my backyard and living near the beach somewhere. That would have been great. So, in 1997, I finished my second year of training, which was at another Philly, suburban Philadelphia program. But moved down to Jacksonville Beach, Florida, and started with a 600 square foot little office, toiling in total anonymity, basically. But followed my passion, which was wound care. But the point of all this, where I'll get to, it's in life, you know, there's little road signs that pop up along the way, and I think it's good to pay attention to them sometimes, even though I was perfectly content. Man, I thought I had it made. Had a little place, little office, got to play men's softball, walk the beach, whatever. It's like life's pretty damn good. But then little things happen along the way, and you find yourself going in directions that you never imagined. But you keep an open mind, and you explore, and you maintain that curiosity. And we'll get into some of the things that have happened as a result. But truly, you know, moving to Florida was to me that was an attainment of a goal in a sense. And I was going to toil, like I said, in total anonymity, just have a good, quiet life and enjoy and be happily ever after. But it's just, it's a crazy ride. And the ride has not been easy at times. There have been many moments where incredible amount of frustration, whether it was in the practice, whether it was developing what became Omeza, whether it was with the foundation. So the point is, I guess, if you believe and you maintain your convictions and you understand your purpose, that you have to follow that, and then you won't feel cheated either. So I think that's one of the take homes of all this.
No, that's brilliant. Maybe let's we'll go over your board professional associations later
Sure.
organically in the discussion, but that leads very nicely into your origin story in wound care. So you complete your residency, you set up to go to Florida, where you can walk the dog on the beach and to quote you, toil in anonymity. What is obvious to me is you've always been an entrepreneur. There's always been this light in you to do things. So what attracted you to wound care in particular, but also the type of wound care you've done, which is very self-driven, very innovative, and very cutting edge?
You know, Great questions, Felly. So what got me into wound care? I never imagined I'd be in wound care. When I went back to school, my goal, I wanted to do orthopedics and do sports medicine, but the universe stepped in. The week before my letter of recommendation was to go off to Rutgers up in New Jersey, I went back to school, did my pre medical stuff in a couple of years. I had worked for 5 years after graduation from undergrad. But anyway, my pre med advisor went out with a quadruple bypass the week before my letter of recommendation was to go in, and I was kind of fast tracking to Rutgers. He was also our pre med committee too, so I would have lost another year. In the meantime, I get stuff from podiatry schools, and it's like, oh, this is kind of interesting. I can do ortho, I can do surgery, sports medicine. Let me investigate this. Well, when I finally graduated from Temple, from the program there, I never imagined I'd do wound care. In fact, the very first week of podiatry school, Warren Joseph, who was one of my professors then, infectious disease specialist, had a slide in his introductory presentation to us as our class of a diabetic foot with an open wound with a hemostat, and now there's pus running out of it. And I just winced. I was like, geez, I'm not going to be doing that. Thank God. It's like, I do sports and take care of kids maybe or something, but no. So you just never know. So now I'm in the VA, my first year of residency, and I discovered an aptitude that was really, though, driven by a desire to solve problems. So I'll frame that. It's one patient in particular. I'll never forget this. I had his chart. This man's been coming into the VA clinic for 8 years for a venous leg ulcer. All they've been doing it every week, 8 years. I'm going through his chart, handwritten notes, betadine, sending him home. Now, this guy was still a pretty vital guy. He loved to go swimming and that sort of thing. So I talked to my residency director. Her name was Ann Sonoga. And I said, Ann, listen, can we do something? Can we try something different for this guy? And I learned about a wound care program or a conference that was going to be coming to the Penn Tower Hotel across from the VA. And it was Sharon Baranowski's program. the conference, and she said, "Yeah, go ahead, learn something, and kind of report back to us." And so at this time, so this is around 1996. You know, calcium alginate dressings were cutting edge, and so now I start trying to get us to use alginates and to use some compression and all that stuff. So at the before I graduated, that guy's wound was healed, and I saw the impact that it had on this guy's life, as well as then being able to try some of the things that I had learned and start to implement some changes. And so it was not the idea to. It was just all about trying to do better. That's all this path of wound care. But I also saw too that as I would make rounds every morning, I'm the podiatrist, and I'm green, and within the first couple of weeks, I'm rounding with the docs from UPenn, Medical College of Pennsylvania, Hahnemann at the time, and it was a team approach. But all the internists were clueless. Every time there was a wound on a vet in the hospital, they'd look to me. And I was like, man, these are the best and brightest, and they don't know how to manage this stuff. I really need to get up to speed on this and learn as much as I can and see what we can do. And that was just, I saw this need. There were guys suffering, and yet a lot of times the solutions were really not that complicated. You could really improve somebody without having to go through a whole lot. So just kind of I immersed myself. But I like to say too that wound care found me, and from there, you try and pass the torch over time. But going back to that period, like I said, we had very little in the way of resources. We didn't have. There was no such thing as negative pressure. There were no cellular tissue products. So it was really kind of really basics, but in a sense, it was good because I learned a lot of good fundamentals, and I really, just applied myself. And again, over time, I learned that a lot of docs who were really bright guys, whether they're vascular surgeons, whatever their profession, people just did not understand wound care, and they'd be content doing the same thing. It's like, no, this is not acceptable. We have ways we can do things better, get people healed up. And as you know, with wound care, you can see the visual impact pretty quickly. If you're making progress, then you can follow that path. But if you're not making progress, then you can change things up. And there's plenty of things that you can choose from. So a little bit of a long-winded answer, but it's just, I think the point is wound care finds you. We're all problem solvers at heart, I believe. We're all trying to do the right thing for our patients, I would hope. And the impact that it can make on somebody's life. You give them back their dignity, their independence, and that's motivation. I mean, I never felt like I was going to work any day when I was going to see my patients. I truly mean that. It was like unwrapping a Christmas present or just seeing what you're going to find, and then most of the time, majority of the time, seeing improvement. And so that's very satisfying. It's very gratifying, and we're kind of doing why we went into medicine in the first place. And one last little thing about being in wound care too. One of the beautiful things about it is we really get to know our patients. We can establish relationships with our patients because we see them so frequently. And the appreciation is there. Many of these people have been told that they have no options or no hope or they need an amputation. So to be able to prevent something like that, and like I said, to restore some independence and function and give them their life back, that's can't really put a price tag on that. So it's been a great ride to date.
And so you leave Philly and you go down to Florida, and Philly, especially Penn in that area, is well known for its medicine. You
Yeah.
talked about the old Hahnemann Hospital. You go to Florida to Jacksonville, which currently has some great hospitals and medical services, but back then, certainly not Philadelphia level. What were
No.
the differences that you saw practicing wound care between what we would call top of the line probably back then and not so top of the line back then?
I think, great question. Jacksonville was at this on the cusp of kind of growing. Mayo Clinic had come down there, and it was starting to attract some really good people, but it was still no. They didn't even have their hospital built. In fact, local community hospital that I joined staff on was also the staff was shared by some of the Mayo staff too. And anyway, so The point is though that it was, I kind of caught lightning in a bottle. Wound care was at the time that the only real corporate type of wound care service or management company was called Curative Technologies. They were based out of Long Island, so their big product was called Procurin, which at the time was a great thing. But by the time I moved to Jacksonville, they started having some problems, I guess, financial. I don't know all it went down, but they ended up closing. So there were some local hospitals in Jacksonville that had curative centers, and then they went under. Now, I opened up a little office, okay, very humble office in Jacksonville Beach, 600 square feet. I shook hands with the landlord. He said, "You can do whatever you want here." So I built out a little office with 2 treatment rooms, and that was it. And I started doing wound care, and before long, the word kind of gets out. And so about a year into this, one of my colleagues calls me, Tom Bronner, and said, "Listen, I understand you like doing all this wound care stuff. Um, I personally don't like doing it. Can I send you my patients?" Like, sure. And this is a guy just down the road from me. And so it started to evolve. And then probably, I don't know, somewhere in there too, Blue Cross Blue Shield caught wind of what I was doing. Now, this is when HMOs were just starting to find their way down to Florida. They were already entrenched in Philly, but I told Blue Cross Blue Shield I wasn't interested, and because I'd seen what happened in Philly. But anyway, long story short, I ended up working with them, and so my little 600 square foot office started to explode. And within a year, or within probably 2 years, I had built a new office that I designed to be a freestanding wound care center. No hyperbarics or anything like that, but it was designed physically so that I could accommodate more patients and do wound care and follow my passion. And from there, Wound Care on Wheels was born too, which is a whole other story. But it was all about finding a need and filling it. There was this real need, but it was also how do we work smarter? How do we work more efficiently? And that's why the mobile service came about, and some of the pitfalls with that too. Some being ahead of our time kind of actually hurt us. But happy to talk about that if you like.
Well, that begs two questions that I think is
Yeah,
fascinating. So, mobile wound care obviously is hot right now. I worked in that space for 12 years, from 2011 to 2023, and obviously a lot of activity in and around that. It'd be great to talk a little bit about what it looked like back then. And then you actually brought up something interesting that we don't have in our show notes, but working with HMOs, I mean, a value based reimbursement, price sensitivity on the part of the insurers has been elevated currently because of a lot of the issues relative to camp products, which has been spoken about extensively by people like Dr. Carolyn Fife. So, if you could perhaps talk a little bit about what mobile wound care looked like back then. Did you go to post acute? What did you do? And then,
yeah.
secondary to that, your interaction with the insurance companies relative to wound care.
Well, let me reverse the order because the HMO thing actually came up first, and that kind of led to Wound Care on Wheels. So again, I'm back in this little office in Jacksonville Beach, and I sent out a little announcement that we're going to do wound care. In before you know it, we got people coming from all over the area. And Jacksonville's a big city, but this thing took off. But when Blue Cross Blue Shield came knocking on my door, literally, they said, "Listen, we have an HMO." I said, "Look, I said I appreciate that, but first of all, you do not pay podiatrists on the same level as you pay other physicians. So I'm not going to accept anything less than a physician." Okay, negotiable. So we got that straightened out. And then I said, "Listen, I also need to be able to do the right things for these patients." Well, they were receptive because they were burning through a lot of money sending patients to HBO, but the patients weren't getting better. So we started a little pilot program. They said, "Can we send you a couple patients?" I said, "Sure." Send them in. To me, not anything real complicated. Diabetic foot ulcers. Now we're getting them healed up pretty quickly because people were never debriding the wounds even. And so now they're thrilled. So all of a sudden they developed this program, and they're excited because we're saving the money. But then things changed at Blue Cross Blue Shield, and they kind of decided to move away from the program. But in the meantime, I had established myself as a preferred provider in their network. Now, where Wound Care on Wheels comes in. Now, I mentioned I had built my own freestanding wound care center. Literally built it. It was brand new construction, designed it, laid it all out how we wanted to. And we were starting to see patients from different locations, basically. So what started happening is we had inadvertently built a continuity of care model. So I would see patients in my clinic, but then I was also seeing consult patients over at the local hospitals. And then I'd follow them to step down hospital and LTAC. And then we're seeing them in skilled nursing facilities. And then what started happening, people get to know you from doing the work at the SNFs. Now I'm getting referrals from skilled nursing facilities and assisted living facilities. We're also realizing how expensive it was to transport these patients to our clinic. 400 bucks at the time by ambulance. So this is back in, let's say, 2006, 2007. It's like, okay, wouldn't it be easier if we just go out and see these patients, whether it's in their facility or ultimately then in their home? So now this time we're also getting a lot of referrals from home health agencies. So you know this, there was a disconnect, and I'll kind of paint this picture. Patient goes into a hospital. They've got a wound. The doc, who's the attending physician, doesn't know how to manage wound care, doesn't know how to manage wounds. So as part of discharge orders, send the patient home. The order, home health, wound care. Okay, that's it. Patient never sees that doc again. Now the home health agency's got the hot potato. Now their bucket of money that they receive for managing this patient is being burned up because the docs, a lot of times they're telling them change daily or going 3 times a week, whatever it was. So understand who's managing the care too. A lot of times it was a de facto nurse who, let's say, had been there the longest in the agency. Now they're the so-called wound care expert. So over time, just developing relationships between discharge planners, hospital staff, but also home health agency personnel, being willing to work with them, started to develop again this continuity of care model, which was not only financially sound, but it was also preventing patients from falling through the cracks. It's very frustrating to have be managing a patient, then they'd end up in somebody else's healthcare system because geographically, maybe they get admitted to a hospital outside of where I was practicing. Now I lose track of them for a while, and then they would show up, and now it's almost back to square one. Well, we had created this continuity of care model, and so found it very successful. The biggest problem we had, though, at the time was that because we were arguably one of the first in the country doing this, CMS and Blue Cross, they didn't know what to make of us. And so I was on prepayment review for about a year and a half. It was very frustrating. I'd have to submit charts, and this is before I had IntelliCure, which this is going to be a plug for Caroline, but this is how I really got to know Carolyn Fife. I brought in IntelliCure, and I wrote an article about this too. If anybody's interested, you can still pull it up online. It was called, I think it was called "Life in the Crosshairs of CMS," something like that, and it details all of this in my experiences. But I brought in IntelliCure, and that's when I started realizing that I was probably underbilling for my services too. That's when CMS finally backed off too. But it was really an incredible exchange and learning experience what went on at that time, and understanding how like CMS was viewing our services. And I got questions from me like, Dr. Bell, why are you seeing so many wound patients? Why are you doing home visits? Do you do a lot of wound care? I said, well, my practice is called Wound Care on Wheels. You tell me. So it's like, well, why aren't you doing stuff that your colleagues are doing? I said, because they don't want to do wound care. I said, it's a bad mix in the waiting room for podiatrists. You've got guys with heel pain, then you've got somebody with an open wound. It's like, it's not good. Wound care patients take more time. You can't work by the clock when you're managing them versus general podiatry. You got 15-minute increments of time. You can pretty much run it like a machine. So I said, I said, I'm not the problem here. I'm trying to save you money and be a good steward of your resources. So I said, and they said, oh, no, we love what you're doing. I said, well, you've got a really funny way of showing the love because you're making my life miserable. You're holding back my payments. And, and I'm guilty of nothing here. I was like, well, we see the codes that you're applying. Like it all came down to a 99232, believe it or not, in the hospital. hospital, follow up service. It's like, okay, so I'm doing the work that you outline in this in your the E&M code that you're questioning. I said, you know why the nurses love Dr. Bell at the hospital? It's because Dr. Bell does the work. He breaks the dressings down. He cleans the patient up. He does the debridement. He does the post debridement dressing. I said, I'm not just in there for 2 minutes saying hi to the patient. So I said, again, you guys are missing the boat on this. So again, so I didn't mean to get off on this tangent, but between HMOs and between, kind of, you know, again, finding that need and filling it, it's not always an easy ride when you're kind of out ahead. I wasn't trying to be anything different. I was just trying to do what I saw was right, and trying to again solve problems that were obvious to me that had simple solutions. But because you're doing something maybe a little differently, then people look at you funny too. I will tell you, if we had had telemedicine back then, we probably wouldn't be having this conversation because we were, we had requests to grow this or to do it, but I was the rate limiting step. I couldn't drive down to Daytona Beach or go up to Georgia or St. Augustine, places where people were seeking our services. So it's like I had to kind of keep it close to home and grow it incrementally. And I hired nurse practitioners, additional podiatrists. But I'll tell you, after a while too, the stress of it all really led to the decision to, okay, enough of this. We don't need the headache. Let's just forget the mobile service. We gave it a shot, and that's it. There's a little more to the story too, even how we grew the thing, but it's kind of fascinating. So
I know that business is stressful. It's funny you should say that because when I joined the mobile wound care group that I finally became a partner in, I was a buck 80, strapping young lad, and it does take a lot out of you. I mean, you have to go to where the patients are,
yep,
scaling,
yep.
recruitment, a lot of the insurance stuff that you have to deal with for trying to do the right thing. And so I think for anyone looking to go into mobile wound care, it's really for those people that are really committed to getting the mission done.
You're so right, and I will even throw this out there too. It's been a little disturbing in the current climate right now with the CTPs and the amniotic products, and some of the mobile wound services that are out there are viewing, applying these products as a revenue stream. That is the least important part of what we were doing. I think, I know we probably did the very first Applegraph in a home setting, and it was all we're just trying to again this person would be appropriate for it. But we never looked at amniotic products as a revenue stream. And this is part of the problem in wound care too. Listen, this is one of the elephants in the room. People for too long have been rewarded for doing procedures versus for outcomes. We've got to be doing better for our patients. You should not be rewarded for just aimlessly putting a graft on because you're making a high revenue. You there are so many people that need our services out there that if you're really doing this right, you can see enough patients in a day and you'll be profitable. You don't have to be taking shortcuts, and then like I said, burning through those resources. We found that balance. We found patients, because we were still seeing patients in our office setting and the hospital consults, and then bringing in nurse practitioners. If a nurse practitioner could see, let's say, 8 patients in a day going to homes, that's a lot of work. And that's a big area to cover in Jacksonville. So that was pie in the sky. We would make that up in other areas. You could be more efficient in, let's say, a skilled nursing facility or an assisted living facility. You could see more volume there. But we still felt that it was so important to do the home part of it because we didn't want these people falling through the cracks, and we knew we were going to have better outcomes, and we did. So that's again, just you do the right thing, and it's not that hard to do. But I think people just don't understand what's really going on a lot of times with how it feels to be that patient first and foremost, or if that was your loved one in the chair. So that should always be your guide.
No, I think that's having traveled widely like you and knowing most people in sort of the high level wound care space, most people want to do the right thing. They put the patient
Absolutely.
in the middle of everything they're doing. And I think a lot of the excesses and abuse that you see is a small minority of people
Hmm.
who do
Agreed.
look at some of these patients as revenue streams. We know the case in Arizona. We know the case of many cases of abuse that we see. And it's unfortunate because it besmirches the whole industry, right?
And that's why we have to have this discussion too, because you're absolutely, and I agree 100%. Most of the people in our community, like I said earlier, we've grown up together. There's a lot of respect because why is a meeting like SAWC or SOC, why is this important? Well, we all get to come together and commiserate sometimes. And we know that, there's times that as you're that clinician, you feel like you're beating your head against the wall. Like nobody knows what you're going through as a clinician dealing with these patients. So to come together with people who share your experiences, it's really cathartic. It's also very therapeutic. You can also learn a lot from each other. And that's the majority of people in this community. Unfortunately, it's always the guys who are the dabblers or the ones who are looking at a way to rig the system somehow. Those are the ones that I have a problem with. And we they need to be called out because they're giving the rest of our emerging specialty a bad name. Whether it's, people look at our research and say this is a bunch of nonsense, or they look at the things that are going on that are giving us this bad reputation by, like you said, using patients as a revenue stream. It's like we have to do a better job of policing ourselves too. I think, unfortunately, but this is here we are, and there's a lot about to go down with CMS. They what we're doing. A lot of the bad actors have created an environment that's not sustainable. And I don't totally blame them either, because CMS had a big part in developing the system that they exploited. So how do we come together and start figuring out ways to solve not just the patient care issues, but the financial side of this too? We've got to be we've got a lot of bright people in this community. I'm sure we could figure this out, but we can't be all doing it in our own silos either.
No, absolutely. I mean, one of the missions of the show is to get people talking and get people like you, your ideas, your experiences out into the general gestalt, because I think they are great people, both on the provider side, but also on the producer side. I'm always, as I talk to more people across the community, I'm very, I interact a lot with the provider side, but I also interact a lot with the producer side. And I can't tell you how many times people who are producing CAM products or technologies are like, we want to do this right. Because if we don't do it right, it's not sustainable into the future. And what we want to do is to bring value over the long run. So there are reasonable people everywhere, but again, this minority of people just they run wild. I remember HBO, remember that, and then prior to that, I believe it was the kits. Margaret Halstead talked about those wound care kits, and then debridement. Remember the growth of debridement, probably from 2008 to 2016. So there's this constant to and fro in the community with products and modalities seeking revenue.
No, that you're exactly right. And yeah, I've been through all those things, and I've seen how, again, certain things have been used, certain things have been abused, and it's all, again, it's all at the detriment of the patients, are the ones who actually lose. Where I get, again, aggravated when I hear certain parties mentioning, oh, if we don't allow patients to continue to have access to these products, people are going to die, people are going to have more amputations. Like, okay, stop that. That's disingenuous. Okay, we were doing good wound care. And in fact, I'll even say that our amputation rates were better before these products hit the market. But they have such great potential if they're used properly. And that's the difference. So, when you do them, when you use these products improperly, it waters down the results. It waters down the real benefit. And so then they're going to be under scrutiny. They're going to go away. You can't just debride every wound. You can't just slap a CTP or a camp on every patient. That's not good medicine. So it's the art of medicine too, and following trends, knowing how to use those tools in your toolbox. That's what separates a good, dedicated professional from somebody who's just a hack. Quite honestly.
No, absolutely. So just taking a step back, and we've talked a lot of you about you as a provider, right?
Mhm.
And I think we could talk for hours about that. But there's a transition that kind of happens with your relationship with the community, and that is you start working with HMP, you start writing, you start doing research, and you start building organizations that are at a national level. Can you walk me through how you got involved with HMP, which is also out of Pennsylvania, and you start your relationship with Viva, Ascent? How did you start branching out?
It's Well, it all started innocently. Again, and I borrowed that line about toil in total anonymity. That was a Seinfeld line when George was talking about somebody who was a podiatrist. It's like, imagine toiling in total anonymity every day. So that was kind of me. Well, I started doing wound care, and some of the guys, I think it was the guys from Organogenesis, they were a fledgling company. They had just started out. They had actually started with Novartis. I mean, I did my first Applegraph in the year 2000, October of 2000. So I'm dating myself even more. But the point is, I was just minding my own business, honest. I had no aspirations to do the dinner circuit or write articles. But there was one guy in particular, Lenny Lamanna, who was working for Organo at the time, where he was a podiatrist, but he'd gone over to industry and he saw what I was doing. The word got back to him, and he said, "Would you be interested in speaking for us?" Like, what do you want me to talk about? Just show some of your cases. And then before you know it, now I'm getting invited to speak more, and then request to write, do a poster. And now I'm at SAWC, and then I'm totally naive to all this. I don't know anybody or anything. I'm just minding my own business again, living the life, man. Playing men's softball, like I said, enjoying life at the beach. But I find myself getting invited to write articles, and just then one thing to another, which then at some point I'm presenting, and somebody heard me present and introduced themselves to me and said, "Listen, we've got a product that stops bleeding on contact, but we would like to see if it maybe has application for healing wounds. Can we come to your clinic?" It's like, sure. I'd always invite people to my clinic, whether it's students, nurses, anybody could come in and just hang out and shadow me, whatever. And so this is how Omeza started. And again, problem solving. So this couple that had introduced themselves brought a third person along with with them and said, "This is Chip. Can he follow you a little bit?" It's like, "Yeah, hi Chip, nice to meet you." I didn't know at the time he was a chemical engineer. His expertise was wastewater and surfactants, and I don't want to really talk too much about his background, but there are household products that are known around the world that he developed. Didn't know a thing about him, but I started teaching him about wound care. And at the end of the first day of meeting him, I said, "Chip, here's the deal. All chronic wounds, everything you saw today, no matter how different they are in their underlying etiology, they all have three things in common. They all have edema, they all have biofilm colonization, and they all have decreased perfusion." I said, if somebody could figure out a way to address those three things, they'd be onto something. Now I figure I'm never going to see this guy again. And I said, "Oh, okay, I'd like to go home and stare at the wall for a couple of weeks and kind of kick some ideas around." It's like, knock yourself out. Never thought I'd see him again. So this is around 2008. So this is when we started working on what became Omeza. We started looking at omega fatty acids as a way to reduce inflammation, to potentially disrupt biofilms, and worked on that for a few years. And then it was quiet. Never thought it was going to turn into a company. And then about 6, 7 years ago, Chip calls me and he said, "Hey, we're forming a company. Do you want to be part of this?" It's like, well, okay, you got my interest, but let's talk some more. And one thing led to another. And at the end of 2019, came on full time with Omeza as the chief medical officer, never imagining that, just trying to help patients get better faster. My patients would lead to the, formulation of a product that would now accompany, talk about an education. But, again, going back, there was no ulterior motive here. It was just, there was a void in the wound care community of products and technology that I had at my disposal. CTPs were good, but they weren't it's not a silver bullet. Negative pressure, great, not a silver bullet. Endovascular procedures had exploded too somewhere around this time. And I was fortunate enough to work with an excellent interventional cardiologist in Jacksonville. And we were able to do a lot of work. But again, there's still this, there's always this evolving need and new things that, technology, the demand needs to be, or technology needs to be driven by the demand, and innovation has to come from, to me, really the people who understand the clinical practice as well. There's so many products that have been, introduced over the years since I've been in the community, and you too. I'm sure you know this. There's a lot of research and copy, I call it, but there's also been products that maybe they sound great in the lab or in development, but they're not practical when it comes time to, getting them into the hands of the patients that need them for whatever reason. So, I thought I brought, the perspective of bringing a brilliant chemical engineer and a wound care clinician and putting our heads together, and with no false pretense. Let's kind of let's work on some ideas here. So you just, again, want to talk about paying attention to the road signs. You just never know where it's going to take you. And from here, it's led to research, a whole new skill set, opened more doors, met so many more people. So the ride is, it's never boring, man. It's never, you know. But again, keep your mind open, keep trying to do the right thing, keep trying to raise the bar, and you'd be surprised where it can lead you. But my story is different than the next guy's too. So that's the beauty of it.
Well, it's fantastic listening to a story about a kid from Paterson, New Jersey, uh, who's traveled the world helping people in wound care. And I think just reviewing your resume, what's again these when I was entering into wound care and going through my journey, I always thought I had an amazing new idea. Oh, this is no one's ever thought about this. And then being bitterly disappointed when you realize people were thinking about it at least 10 years prior to you. And realizing that many of the issues in wound care are sort of in the cyclical kind of thing. And over time, it's the same issues, but maybe a combination of those issues at that particular time. One of the things you mentioned was around research. I know that you've dealt with real world evidence. You work with Carolyn Pfeiffer and IntelliCure. What are your thoughts on real world evidence versus the classic study? Or as you might have called it, research and copy or something like that. What are your thoughts about that distinction in wound care and the benefits of one versus the other?
Yeah, so great questions, Veli. And so now my role with Omeza coming on board has been to design clinical trials, to implement them, then to get the results published, continue writing. And so it hasn't been always clear cut or a smooth, linear, path in that regard. But you touch on something that's important. And this is part of the issue with as wound care evolved. We call our experts, our community, the Wild West. And it really has been. But I also hear the same thing from the cardiology groups and everything. So, but we have our own little version of the Wild West. So with that, because there was everything was wide open, in terms of ideas and collaboration and developing products, and you know how one thing would lead to another. Well, because there was such this rush to get things to the market, I think we haven't always done our proper due diligence, and the research has been lacking. And not to bash anybody, but as before I ever was with Omeza, or even before developing the products, I'd look at some of the studies that I'd be handed or I'd come across, and I was like, this is so obvious that this was just designed to make the product look good. And that's an issue I have. And you look at some of the wounds that were being studied. It's like, okay, well, this is fine, but this is not what I see in my clinic. And I will tell you, in the arc of my career, the acuity level became ever increasing. People were sicker, they were younger. So the point is, okay, there's a sense of urgency here. We have to do better because this is not getting better. Diabetes is exploding, as for one. When I'm up in Philly doing my residency, we had 16 million people with diabetes in 1996. Felt we were close to a cure. Where are we now? 38 million, 88 million pre-diabetic. This is you talk about the elephant in the room. So, talk about a need to do better, because when I said there's volume, there's work for everybody, there really is. But we have to be able to offer them better things. So, I think at the end of the day, collaboration is so important, but we have to tighten up our research. Real world is important. I felt coming onto Omeza, okay, having been in the wound care community for 25 years, okay, if we're going to take this product out to my colleagues, I have to be able to look them in the eye and know they have to know that I'm not feeding them a bunch of BS. First of all, I'm also in their shoes because I know what it feels like to have these train wrecks coming in. And what do you do? And you want to have other things to use and offer your patients. So that's what was driving, this. Vicky Driver has led up this wound care collaborative community, and they've worked with the FDA to look at real world evidence. We have to go real world. Our patients don't come in and, okay, they're diabetic. Well, okay, a lot of times people with diabetes get slammed that they did it to themselves. I disagree with that. But the point is that you've got patients who have excessive BMIs. We have smokers. We have people who live by themselves, maybe don't understand how to do offloading. There are all these things that factor into it, but you've got to have a product that, as you're developing your product, as I talked about, there's got to be practicality, but it's got to be practical across settings, who's applying it, how it's being used. And at the core of it, though, you've also got to do research to validate that it actually works. You can't just use anecdotal. There's far too much anecdotal work out there. So I think it really behooves us to do higher levels of research. And real world data is really going to be an important part of what happens in wound care. Fortunately, I really think we need better.
Yeah, no, absolutely. I think we've been very fortunate at Open Wound Research, where our sponsors have been very progressive when doing some of these studies, because at the end of the day, you've seen studies where the let's say it's pressure ulcers, right? And the study is looking at pressure ulcers, but it's not differentiating the time to treatment, right?
Hmm.
That's a huge. There's a very big difference between a stage two pressure ulcer versus a stage four. And so understanding what is the cohort you're treating, understanding that certain products are entering into the treatment continuum far later, and judging them accordingly. When you see real world evidence where you see heal rates of 50% on an SOC arm, I start going, what kind of real world evidence is this? Because I've seen a lot of data. And when I see
Okay.
that number, it just jumps out at me that this population is healthy yeah, than the general population that a clinician like you sees. So,
Yeah,
yeah, there's
yeah.
issues.
Yeah, to your point, pressure ulcers, there's obviously staging. We've seen this most recently. We've been doing some VLU work, and I'm looking at it and say, you know what? There's some problems here. How we classify even VLUs. Okay, are the venous leg ulcers the result of a varicosity, or because of perforating issues between the superficial and deep system, or is there chronic DVT involved that hasn't been addressed properly or is still there? And data gets skewed, especially who's doing the research, who's doing the actual investigation. We've got to really have honest conversations, and really, if industry is going to survive a lot of this, well, they've got to also be active participants in cleaning this up. So
Yeah.
I'm
No.
with you, man. I'm with you 100%.
Yeah, and I think there is a coalition of the willing, right? People
Yeah.
who've seen what's happened with the bad actors and who are going, guys, we need to tighten things up, and we need to actually do good research. A lot of our focus has been on quantitative methods, because any specialty, if you look at the success a specialty has, or like for example oncology, a lot of it's a disease state that is has high prevalence, of course, but also the development of quantitative methods that really explain what's going on and can tell a story. I mean, at the end of the day, statistics, quantitative methods are about telling a story, not running a test, not doing. It's about creating a story that people can understand how something works and whether or not it's efficacious or not. And more importantly, when it is efficacious, because nothing is omni efficacious. I mean, that's absurd. We had Marissa Carter on probably, gosh, 8 episodes ago. And I really enjoyed talking to someone who had been in the industry a while because she's asking the right questions and trying to tell the stories statistically and quantitatively. So to your point, I think we do need to do better. And thank goodness there's a coalition of the willing who are going, hey, this is what we need to do. And of course, people will say, well, it's in response to the LCD with grade and all that. But I think this was happening beforehand, to be honest.
Yeah, yeah, I'm glad you brought up Marissa. Just a brilliant mind and great person. And now I'll speak just from my perspective too. I'm fortunate. I'm really fortunate. I've worked side by side with my colleague at Omeza, Dr. Suzanne Bakewell. Now, Suzanne didn't come from the wound care world. She was a Komen Fellow, so her expertise was breast cancer research and oncology. And one of the things that you just mentioned too, she's always harps on, okay, what are the questions that we want to answer? And that's you start, but then what made me where I'm going with this, Felly, is that I think that what we need to look at, I hopefully as we do better, it's going to attract more minds like Suzanne, where we bring in some people from outside of the wound care arena, but have expertise in research in other areas, and we can start to collaborate with them. People like myself, who's the clinical background, work with these types of people. That's how we get better. A number of years ago, I'll just tell a quick story. I was invited to a think tank up in DC, and it was primarily interventionists, cardiologists, radiologists, etc. And there were two of us who were wound care docs, and the FDA was there, CMS was there, and to hear them really ripping on wound care and the research, they thought it was a joke. And I remember talking to the head of CMS at the time, and I said, "Listen, you guys helped create this environment. It again, whether it's billing or it's even the research, where's the incentive to do better? If everybody's coming in as a 501k, why would a company want to put at least 7 years of research in and do all these studies before they come to the market, and then you pigeonhole them? Using Applegraph as an example, one of the three or four products at the time that had taken the pre-market approval route to market. Great product, would have been perfectly successful using head to toe. But because they did their PMA studies on VLUs and DFUs, that's all they were indicated for. So, this example. So now you got other things. Everybody takes a 501k approach to the market, but they don't realize you're lumped in a category with a piece of gauze. It's negative pressure, same categorization, which there's something fundamentally wrong with this. So again, how do we do better? But I think going the research route, attracting like really bright minds to this, pie in the sky, but it can be done. But also, where do we have to go with this? This is so important.
No, absolutely. I think I might have mentioned this on a previous podcast, but I think I subscribe to the Schumpeterian school of creative destruction. Like, if you look at each of the periods of disruption in wound care centers, etc., it brought new people into wound care that would have not come, right? So, Healogics, all these people coming in, and by the way, Healogics was out of Jacksonville, which
Yes.
I just remembered, you know.
They were literally about 2 miles from my office, but I never worked with, even though I have friends over there, I never worked with one of their centers. So,
Yeah,
we were just working, it was like parallel play in the sandbox. I was doing my thing, they were doing theirs. Again, there's enough work for everybody. But anyway, not to
yeah.
digress.
No, it was just funny because I just thought about that. But I think each of these even the recent camp sort of growth has brought new minds in, and even if that ends in its current manifestation, I don't think it's going away. But there might, well, most certainly will be some changes. It's brought new people and new minds and capital into wound care, and I think
Yeah.
that's what's going to sustain this community over time and this part of the market. So in a weird way, I think we need to go through these cycles and go through the maelstrom of oh, we're overutilizing, etc., but then correct. and then someone will
Yeah.
find the next thing, and off we go.
Yes, exactly. We've seen this, and yeah, you just took the key word. To me, like an economist would say, every once in a while, I have market correction, and so there's a correction underway right now, and it'll be a good thing. We have to remain positive, optimistic. Anybody who's in wound care, you inherently are positive and optimistic. We're the ones who take a look at a nasty wound and say, "Oh, that looks great." So we see things a little differently. But yeah, we right now we're kind of shaking the bushes a little bit. We're getting, we're cleaning things up, and it's needed because it was not sustainable what's going on. So it's okay. We'll all be better for it, and I think there will be a higher level of respect in within the medical community too. Right now, I don't always get that sense from even from investors looking at wound care to put their money into. It's like, this is just like a bunch of nonsense. This is hocus pocus, or it's just so it really, again, there are a lot of reasons for urgency to do better.
Absolutely. We have about 5 minutes left here, and I do want to give you an opportunity to talk about your foundation, the Save a Leg,
Sure.
Save a Life Foundation. So, if you could perhaps talk about that, what is the mission? What are you trying to do? And what does the future look like?
Yeah. So thank you for that. So the foundations, the Save a Leg, Save a Life Foundation is a nonprofit. It's a 501(c)(3) organization, and we were dedicated and founded, again, not originally with the vision to create an international organization, but all we were trying to do is make things better in Jacksonville, Florida. Where it all came from was seeing patients struggling because there was a lack of education or understanding. Um, and so we were just trying to do better. So we started out by having a lunch and learn with 12 directors of nursing of local home health care agencies in Jacksonville. And I started talking about wound care and some of the products that were available to them. And the thing snowballed. So, where we are now today, again, a nonprofit whose mission is to reduce unnecessary lower extremity amputations that are the result of a lot of times undiagnosed peripheral arterial disease and chronic wounds, and getting people to getting them educated better, whether it's providers, whether it's patients, but it's really all about taking care of members of our community. And at the end of the day, I want to see amputations reduced. I want to see our organization become a household name, because if it will become that, then that means that we're going to help people become their own advocates. And that's the essence of this. You know, I always compare this to breast cancer research. We all talk about the 5 year mortality rates of diabetic foot versus, let's say, breast cancer. And that, sure, that's all true. We have so many more people with diabetes and open wounds on their lower extremities, not even getting into pressure wounds and all these things. So we've got this very, let's say, unglamorous part of medicine that people like to sweep under the rug, but it's a total drain on our system. But if we can teach patients to be their own advocate, know how to look for warning signs, especially if they have risk factors, whether it's their diabetes, whether it's ethnicity, whatever it is, smoking, we can teach them how to understand that it's better to be proactive than wait till it's too long and then you show up in an emergency department. Then we start making improvement. Instead of waiting for these people to become really Hail Mary cases, let's get them early. I would always say so many times, man, if I just seen this person 2 weeks ago, we could have done something, or something more beneficial. Now we have to do a more aggressive amputation, let's say. So again, it's like teaching people. We taught women and even men how to do, breast self-examination, look for a lump, or buddy checks, or men testicular evaluation. You do that with people who are at risk. Now you can start to nip a lot of this in the bud. And why SalSal exists? Because we haven't done a good job of driving this message to the public. We go to conferences, we talk about all this stuff, but at the end of the day, what are we doing differently? Amputation rates are still going up, so we're failing. We've got to come together as a community and really start moving out into communities to do things like community screening events, our White Sock campaign, helping people who don't have insurance get the things that can be preventative in terms of turning into let's say they've got a callus on their foot, get them some diabetic shoes, whatever it is. So there's ways to do this, but we've got to drive this messaging to the public.
No, absolutely. We'll leave the details for the foundation in the show notes. That sounds like something that we all should support. I know Dr. Armstrong as well advocates for this kind of work. It's an important thing and it's global in nature. I mean, even back home in South Africa, we have the fifth highest obesity rate in the world, and some of the same issues are happening down there with regard to
So
limb issues.
yeah, it's mind blowing. When COVID was going on, I kept constantly telling people, like, guys, diabetes is the real pandemic. That this is exploding globally, whether it's South Africa, whether it's the Middle East, whether it's Latin America, not just the U.S., India. All these places are hotbeds of diabetes, and therefore wounds and amputations. And then when you look at all the bad things that happen or that are associated with non-healing wounds, we've got to do better, and we can. That's the thing. We have technology, we have the ability, but it just seems like we're working in silos, or the message isn't getting where it needs to, and that's where the frustration comes in. So I appreciate you, giving me that chance to this platform to even discuss this. But yeah, we have to do better. It's affecting everybody.
No, absolutely. Final question that we have for you today, and I feel like we could have spoken for numerous hours. I know prior to the podcast, we talked for 10 minutes about all things Philadelphia and North Jersey. That was fun. But if you had infinite time, infinite resources, and you could solve one problem in wound care, putting aside the Save a Leg, Save a Life Foundation, which I think takes position one, double asterisk bolded. But if you had to choose something else that you could resolve in wound care, infinite money, infinite resources, what would it be?
Oh boy, that is a great question. It goes back to having been that person who's amputating a part of a foot or a toe or whatever. You don't wish this on your worst enemy, when you know what's going to come. So if I had unlimited resources, I think it would go back to what I was just talking about. What we put on wounds is the least important part of the equation. Okay. Healthy people do not develop chronic non healing wounds. So, how do we work to educate and prevent people and let them know that because they have certain risk factors, like certain ethnicities do, how do we let them know that it's not a foregone conclusion that they're going to become a statistic? So I would just say, in my grand scheme of things, my legacy would be to, if I had unlimited funding, get this out in the open, get this out of the shadows, and the shame that goes with it, and the people feeling isolated. We have to. I would love for us to figure out some type of way to, again, get people to be proactive in their own well-being instead of reactive and just handing it over to somebody else to manage their situation. It's all about quality of life. We all have a certain number of days that we're going to have. We never know when we get called home, but we have to, while we're here, you want quality of life. You don't want necessarily quantity. Watching that downward spiral, it's a terrible thing. So whether it's cancer, whether it's diabetes, kidney disease, all these things, we should be striving to do better and maintain our health individually, and again, giving people the tools so that they understand how to make the right choices and decisions.
Absolutely. Well, thank you for that. This has been a great hour. In closing, I think it's this mission that you're pursuing. I think there's an interesting idea that occurs in stoic thinking, right? In stoic thinking, you think about the bad things that can happen to you, and then you work your way backwards. How do you create a life where those bad things are less probable to happen? And also, if they were to happen, how would you deal with them? And with regard to getting people to change behavior, I've always thought of creating an application where you have the reverse clock. So you take a arterial table for each person, you do a countdown clock, right, to their prospective death, and then you say this is the time. And it really, I think, it's a macabre idea in a sense, but it also puts into people's mind that time is also backward flowing, and that for each minute that you're living, it becomes more valuable. And I think that's kind of the idea that you're touching on in getting people to change behavior, myself included, is let's think backwards. What do you want in your life, and what are the things that are important to you? And this is each unit of time that's passing is very important. So I just love that. I think it's important. I think it's the key to solving many of the issues we have in healthcare in general, but wound care in particular as well. So I thank you for that.
Oh, my pleasure. So, you just, it's like the Benjamin Button approach or something. We kind of, I wish we could go backwards, but we can't. And so, here we are. And so make the most of it now. And again, I keep saying, be proactive. Don't, yeah, just don't rely on somebody else to do it for you. Don't look for a pill to be the magic solution. Don't look for a product to be the silver bullet in wound care. Just, it doesn't work that way. We're given this, we're carrying around with us an engineering marvel that is designed to repair itself and heal itself, but you got to take care of it. I used to tell my patients all the time, if you could put 93 octane in your car or 87, what are you going to pick if all things were even? 93, of course you would. You want to take better care of your car. We're all like cars. Our parts are all going to give out sooner or later, but you maintain it, you do the best you can, and try and maintain that balance too. I think it's so important, whether it's the physical, the mental, the spiritual, it all comes together. It's so important. And, we should all be lifting each other up in the process too. I think that's so important. So anyway,
Brilliant.
that's,
Well,
we
thank you
keep
so
talking about
much.
what you said.
Well,
It's
talking
been a
about lifting each other up, you've been doing that all your career, and I thank you for the work that you've done and can continue to do. And I hope the audience enjoyed the past hour and 10 minutes, and I think it's been incredibly valuable. And I thank you for your time.
Thank you, Zwelly. Thank you so much. It's great to have you as a colleague and a friend, and I really appreciate this. And I look forward to, again, further collaboration. And you know where to find me. I'm always available to you for anything. So just let me know. And you know, likewise, it's been a great time today. So thank you.
And that, ladies and gentlemen, is the great Desmond Bell. And I hope you enjoyed this episode. And this is Willie Tini Tuniswa signing off. See you next time.